Good morning. I'm Mona Broy, Chair of the Town of Lexington Human Rights Committee, the civil rights arm of your town. Welcome to our annual MLK Day community conversation on race. Please be sure that you are muted and that your video is turned off. Now I welcome longtime team member Richard Rhodes to open our program with a prayer in honor of MLK, who was first and foremost a minister.
Good morning and welcome. As we all know, Dr. King was a person of vision and passion and nonviolent action, but he was also a man of deep faith and prayer. And I've been very inspired by some of his prayers. And so I'm going to use his own words this morning. Eternal God, out of whose absolute power and infinite intelligence the whole universe has come into being, we humbly confess that we have not loved thee with our hearts, souls, and minds, and we've not loved our neighbors as you have loved us. Grant that we will follow you and become so committed to your way and your kingdom that we will be able to establish in our lives and in this world a brother and sisterhood, that we will be able to establish here a kingdom of understanding where men and women will live together as brothers and sisters and respect the dignity and worth of every human being. And we ask you, God, in these days of emotional tension, when the problems of the world are gigantic in extent and chaotic in detail, to be here with us in our going out and our coming in our rising up and our lying down, in our moments of joy and in our moments of sorrow, into the day when there shall be no sunset and no dawn. Amen.
Thank you so much for that inspirational opening, Richard. I think great minds think alike. For I now turn to the words of Martin Luther King Jr. Of all forms of equality, injustice in health is the most shocking and the most inhuman because it often results in physical death. Today's topic on racial injustice in healthcare and health outcomes is both a timely one and sadly, a very old one. We already know about the disproportionate impact of the still raging COVID pandemic on people of color, particularly on the African-American community. Not only nationally, but even right here in our backyard, in our hometown of Lexington. But it's not just about COVID. As we will learn together today, it goes much deeper. It's multi-layered and multifaceted. We have had over a half a millennia of racism on this land and centuries of healthcare inequities that have led us to where we are today. When the Lexington Human Rights Committee declared that racism is a public health crisis in Lexington, we knew that it was just the beginning of the work that lay ahead, not only for us, but for everyone who lives here. For all of you who logged in or are watching on LexMedia to listen and learn from these brilliant speakers, thank you. Showing up today is a first step to make sustainable, impactful change. We are blessed today to have Assistant Speaker of the U.S. House of Representatives, Katherine Clark, who has a very busy schedule, but cared enough about this topic to attend. She will share her thoughts, and she will also continue to be a voice at the federal level, advocating for policies to mitigate some of the systemic issues that result in these unjust outcomes. Our featured speakers, Dr. Allison Bryant and Dr. Jocelyn Carter from MGH, are not only incredible physicians, but leading experts in the field of public health and racial equity in the healthcare system. Their deep knowledge is usually shared with their colleagues, but today they have chosen to share some of their wisdom with us. I hope that everyone will give them their undivided attention and work towards being part of the solution. There is no equivocating, there is no choice. If we want to be a just society that values all human life, then we must all work together to make the systemic change that is long overdue. Today, is a chance to save lives. With that, I turn it over to Melanie Thompson to introduce our first speaker.
Hi, everyone. I want to welcome Congresswoman Katherine Clark, who proudly serves the 5th District of Massachusetts. She has recently been elected to the Assistant Speaker of the House, and she was first elected in a special election back in December 2013, which I really remember. We are so happy to have you here today, and we welcome you to Lexington's community conversation. Thank you so much.
Thank you, Melanie, for that kind introduction and for inviting me to be here with you today. And thank you to the Lexington Human Rights Commission for convening this important conversation. You all remind me of the words of a young student in Malden at a Black Lives Matter rally that was held back in June. And she said, "I challenge you to teach me my worth." And all of you, by being here and having this conversation, are teaching our children, all of our children, their worth. And the theme of this year's conversation could not be more timely or pertinent. As Mona already quoted, nearly 55 years ago today, at the convention of the Medical Committee for Human Rights, Dr. King said, "Of all the forms of inequality, injustice in health is the most shocking." And over the course of this pandemic, we've seen these inequities play out. We've seen them because they have long existed in this country, but we have seen their deadly effect. Black and brown communities have experienced significantly higher infection rates, hospitalization rates, and age-adjusted death rates than their white counterparts. And they have borne the brunt of the economic devastation this pandemic has brought. At the same time, after the brutal murders of George Floyd and Breonna Taylor, our nation has engaged in a long overdue truth-telling about the systemic racism and economic inequality that permeates every aspect of American life. Unequal access to healthcare, food, affordable housing, broadband, and clean air and water have left pockets of Americans struggling to stay alive and stay afloat. We are looking for solutions to so many challenges, from police reform to affordable healthcare to education equity. We must meet this moment of historic challenge with historic progress. It could not be clearer that it is not good enough to return to normal after this pandemic. We have to build a recovery that is inclusive and just for all. In the short term, our focus must be on building trust in minority communities, boosting testing, expanding contact tracing, and equitably distributing and administering vaccines. And I am so grateful to be here this morning with Dr. Bryant and Dr. Carter, and for their work to make sure that our communities of color are no longer underserved by our healthcare system. And that includes bolstering public health and primary care, addressing social determinants of health, and dismantling racism in the healthcare system. And with Democratic majorities in the House and the Senate, and finally a true partner in the White House, we are going to tackle these systemic inequities, and they will be the priority in everything we do in Washington. We have a lot of work to do as we stand at this crossroads of economic, racial, and climate justice. But I remember the words of my friend John Lewis the last time I heard him speak. It was right after George Floyd's brutal murder. And he said that he was grieving that the soul of the nation was not in better shape. But seeing the protests, seeing the wide swath of Americans who were fighting for reform. He said he had never been more hopeful. And I want to share the words that he told us. Do not grow weary. The winds of change are blowing. So all of us are going to heed those words. We will unfurl our sails and catch those winds and make sure that we are building a nation that lives up to our promise of liberty and justice for all. I thank you for convening this morning and for letting me be a part of it.
Thank you. Wow, you brought tears to my eyes about the civil rights icon, John Lewis. Just a couple of questions for you. One of them is the Lexington Human Rights Committee, Board of Health, and School Committee have all declared racism to be a public health crisis. Recognizing that government has an important role to play in dismantling racism, what legislative action can we support or request to work toward dismantling racism?
Well, thank you so much. That is the question. And we have to make sure that access to healthcare is at the center of the work that we are doing in addressing this pandemic. And if we put equity at the center of all our legislative proposals, we can finally address structural and institutional racism in our country. But let me give you a few examples of specific legislation that I think is important. We have to lead on language on the social determinants of health. The final language that I have been putting forth is asking for an exploration of how Medicaid and CHIP could better support issues stemming from social determinants of health, which are factors that present a barrier to improved health and successful patient outcomes. We have to make sure that we do the research, that we fund at the CDC the research into why excessive deaths are taking place across communities of color. And we have to support the bipartisan birth access benefiting improved essential facility services, which is a long way of saying the Babies Act, to improve health outcomes in communities that lack access to maternity care by expanding access to freestanding birth centers for Medicaid recipients. We have so much work to do around healthcare and expanding and protecting the ACA so that everyone in this country can access healthcare as a right and not a privilege.
Wow, thank you. That's a lot.
And there's more.
Well, that's good. We're happy that there's more. So in the spirit of MLK Day, and just to lighten it up a little bit, can you tell us some stories about what it was like working with civil rights icon John Lewis in Congress? He was such an icon for us all.
He was an icon. And Melanie, I can tell you that he was one of the first people that I met when I got sworn in a special election. So I was sworn in all by myself. And, you know, I'm very fortunate that I get to meet sort of luminaries of our political system all the time. But when I met John Lewis, I was completely tongue-tied. I could not even believe that I was a colleague of John Lewis. And he always wanted me to call him brother or John Lewis. And I had a very difficult time ever calling him anything but Mr. Lewis. But he was just, I heard him described once that he was a living sermon. And I think that's a beautiful description. He was just one of the kindest, gentlest, just embodiment of peace and love that you can ever hope to meet. And he greeted everybody with such dignity and respect. And some of my best times with John Lewis was walking back and forth to votes across the plaza by the Capitol. And on one of those, I had a group of people recognized him. They were in a cab going down Independence Avenue, and they literally started to jump out of the moving cab because they were so excited to see him. And he was like, no, no, brothers and sisters, you know, be safe, be safe. But just the way he greeted everybody, whether they were a powerful senator or someone working on the grounds at the Capitol. Everybody was greeted with the same way. And getting to cross that Edmund Pettus Bridge with John Lewis is one of the most moving experiences that I've had in my life. And I hope all of you will get a chance to do the Civil Rights Trail. I wish you could have done it with John Lewis, because that's a remarkable experience. But he has left a real legacy of the way forward for all of us. And we have to heed his words. And I always think of the Bible phrase, to do justice, show mercy, and walk humbly. That was John Lewis.
Oh, it's so sad that he's gone. So speaking of sad, I'm just curious about your thoughts about the impact of January 6th on all, especially people of color's mental health. That, I mean, it was really a tough day or tough period for all of us. So I'm wondering if you could talk about that, what we can look forward to in addressing these mental health issues in the new administration, how things are going to happen, and how you personally felt that day.
Yeah, you know, I'm very much still wrestling and processing January 6th, but white supremacy came home to our Capitol on that day. And this was an insurrection. It was seditious, treasonous, violent, but it also is the result of the deep and toxic roots of slavery that still pervade all that we do in this country. And I think it's an example of how white supremacy does not just impact communities of color. It holds back everybody, whether you think you benefit from it or not. But the impact of having that display of hatred, of violence, fueled by bigotry in our nation's capital has a very different effect for people of color. Those symbols of the Confederate flag, the battle flag, for the first time being flown in our nation's capital, of a noose and a gallows erected outside of our nation's capital. People wearing shirts, you know, that were saying 6 million is not enough in Camp Auschwitz. All of this has a very different impact. And, you know, one of the stories that really sticks with me from that day is a very dear friend of mine, Lisa Blunt Rochester, a congresswoman from Delaware. And she is also just a lovely person and a fighter and a very strong Black woman. And when she was finally rescued from the gallery in the house, where she was for about a half an hour, not knowing if she was going to make it out, everybody was told in Congress to take off our congressional pins because it would identify you as a member of Congress. And for Lisa, that choice was very difficult because she wasn't sure what was the greater threat. That if she took that pin off, she wouldn't be recognized as by law enforcement as someone worthy of protection, or if she left it on, would she be recognized, you know, by this mob as a member of Congress and be victimized? I've never had to make that calculation in my life. And we have to do everything we can to seize this moment of racial reckoning and make sure that all those virtues that we talk about in this country, liberty, justice, equality, truly apply for all. And that's getting to the hard work of looking at healthcare policy, of looking at education disparities, of looking at climate justice. All of these things feed into our grappling with this moment and meeting it so that we can continue to have a democracy that is representative of Americans. And democracy is not self-executing. And I think whether we succeed in this American experiment is very much up to us and how we address racism in this country.
Thank you. Well, we have about 1 minute left to wrap up. So I just want to thank you again so much for coming today and just to hear some hopeful thoughts from you for what we can expect for 2021 after Wednesday when we have a new inauguration.
Yeah, we can't forget, you know, John Lewis told us, do not get weary. Keep looking for that hope. I find it in all of you joining this call. You know, I've heard that this is oversubscribed, and that is good news. Don't forget the optimism and that working for justice is not easy work, but is work of such promise. And I am so grateful to everyone in this community and look forward to working with you to meet this moment in our country. We can change. Things do not have to stay the same. And working to make sure that healthcare is accessible to all is a great place to start this critical equity agenda.
Thank you. Thank you so much. I don't know if everybody's on mute, but I think we should give her a round of applause for saying such motivating words. And now, thank you again so much. And I think I'm turning it over now to Tanya.
Yes, thank you. Thank you, Assistant Speaker Clark. We deeply appreciate you being here today and for sharing your passion with equity, supporting healthcare and healthcare outcomes. I am proud now to move on and have the honor of introducing our featured speakers. Dr. Bryant explores disparities in obstetric care and outcomes in low income and minority women. She is now the Vice Chair for Equity, Quality, and Safety in the Department of Obstetrics and Gynecology. In that capacity, she works toward equitable outcomes care for all patients. She currently works with several regional and national women's health and equity improvement efforts. Thank you, Dr. Bryant. We are happy to have a fellow Lexingtonian here with us today. And now for Dr. Carter. Dr. Carter is passionate about addressing gaps in healthcare equity for students, trainees, faculty, and staff. As a clinician scientist at Mass General Hospital and an instructor at Harvard Medical School, her research is focused on improving healthcare outcomes for vulnerable patient populations. Dr. Carter serves as the Diversity and Inclusion Manager of Trainee Affairs and the General Internal Medicine Director of Research Equity at MGH. Welcome, Dr. Carter. And without further ado, I am going to yield the floor to our speakers. And if everyone in the audience could please turn your video off by just clicking on the video button at the bottom so we can highlight our speakers for this conversation. Thank you so much.
Good morning. Thanks, Tanya, so much. It looks like a screen share has been disabled. I'm not sure if someone can help me to be able to screen share, or at least can load up my slides.
Yeah, hang on. I will make sure that you have that option.
Thank you.
I just have to find you on the list.
It might be with the A's. I really am very excited this morning to be able to talk with you all about something that I am quite passionate about. As you heard, I am a high-risk obese specialist at Mass General Hospital and have been there for about 10.5 years, although I trained here in the Boston area before moving to San Francisco and then moving back to Lexington. And so the roles that I sort of bring to you today is as vice chair in the OBGYN department for quality, equity, and safety, which is a role that I crafted really to sort of honor the fact that there really is no quality of care without equity of care. And then I also have the great honor of chairing the Massachusetts Maternal Mortality Review Committee, which is the committee that is mandated by the state to review all of the deaths of women in the context of pregnancy or in the postpartum period. Okay, thanks so much. I'm just going to load these up. So hopefully you can see my screen and see my slides. So I've told you who I am, but above all of those things, indeed, I am indeed a proud Lexington resident. I've been living here for the past 10.5 years with my family. And so it's an honor to be welcomed into this community to speak. So one of the things I was asked to talk about today were really health inequities and where we are today, where we have come from and where we are going. And so glad to partner with Dr. Carter this morning to speak about these things. So one of the things I think is really important is just sort of setting the stage in terms of definition so that you know that what I'm talking about. So when I use the word disparity, I use the Healthy People 2010 definition, which is really just the quantity that separates a group from a reference point on a particular measure of health, oftentimes expressed as a rate, a proportion, a mean, or some other quantitative measure. And oftentimes we measure that from the most favorable group rate, which in the United States oftentimes is a comparison to white patients or white populations. But the term I've tried to morph to more frequently is really thinking about inequities. And this, as least defined by the Boston Public Health Commission, is a difference in health that's not only unnecessary and unavoidable, but really unfair and unjust and rooted in those social injustices that make some population groups more vulnerable to poor health than other groups. And so that's the term I tend to use. I tend to slip back into disparities language every now and then, but really I want to speak about inequities today. One of the things that's really important, I think, is sort of distinguishing health outcomes inequities from health care inequities. So both exist and both are really important. For us in the healthcare space, I oftentimes hammer home those healthcare inequities, the ways that we treat patients differently by who they are and what they bring to their table. An example here of just a health outcome inequity would be life expectancy, right? So people that are born here in the United States have different life expectancies by their race ethnicity. So white patients enjoy a greater expectation of life and health for longer than do Black patients or Black populations. If we think about healthcare inequities, that's really what happens to you after you enter the doors of the healthcare system. So this is one that is, we tout a lot, which is that Black and Hispanic adult patients and Black pediatric patients are less likely to receive adequate analgesia for painful conditions in the emergency room. So if a child shows up with a long bone fracture and they are Black, they are less likely to get adequate pain management than is the white patient in the bed next to them. And this was all highlighted by Unequal Treatment, the Institute of Medicine sort of document that really documented what patients experience within the doors of the healthcare system. My field is OBGYN, so I have most of my experience in disparities or inequities in OBGYN. And so these are some of the highlights that we wanted to bring forth in our committee opinion. So ACOG is our professional organization. And I helped to write this document that really highlights the inequities that are in our field. So things like infertility or fetal death or breast cancer mortality, much higher amongst African-American or Black populations. And then we also wanted to highlight those things that were inequities in healthcare in addition. So Black women less likely to have adequate mammography, or Hispanic women less likely to have adequate Pap testing, Black women more likely to be delivered by cesarean delivery. So what can we do to unpack some of those disparities or inequities? Many of you may be familiar with this ProPublica series called Lost Mothers, which really sort of, I think, highlighted for the lay public and for all of us this tragedy of maternal mortality, or women who die in the context of pregnancy or in the postpartum period. And it's really quite a tragedy that in the United States, we're really the only developed country that over time has had a rise in the maternal mortality rate as compared to other developed or countries or high income countries. And what's even more tragic, obviously, is the inequities within those rates. So in the United States, Black women are 3 to 4 times more likely to die in pregnancy or in the postpartum period than are white patients or their other counterparts. we really, for the past decades, but particularly in this past year, have been forced to reckon with the effects of systemic and structural racism and their impact on Black and brown bodies. But in obstetrics, we have our own list of names that we never forget, of those individuals gone far too soon, from Shalon Irving in the lower left that many of you may have heard about, who was the CDC officer who herself studied health inequities, but herself died within the first few weeks after her delivery, to Kira Johnson, who was the daughter-in-law of Judge Hackett, who is a TV personality who died of a bleeding complication that likely was preventable in the West Coast, to many others who lost their lives way too soon. And these are the names that sit with us as we do this work. So I was asked to talk a little bit as well about health inequities and sort of how we got to this space. And as I really scratched my head to sort of say what to say here, all I could think about is sort of how did we not get to this space, right? This is clearly an American legacy and an American problem. We have, our legacy is the legacy of slavery, in which children and families were separated on the regular, in which we have sort of, differential access to things like education or to healthcare or to funeral services. We've always sort of struggled with sort of police brutality. And as the sign says, racism is a pandemic. And what I would say, and I would posit, is really that racism is endemic to the American experience. And so, of course, we have these legacies of health and healthcare inequities that are left behind. So just to give a little historical context, again, from my field that can sort of let you know what we are dealing with, is J. Marion Sims was a surgeon in the 19th century who specialized in gynecology and has been considered to be the father of modern gynecology. And yet the work that he did to perfect techniques on things like fistula repair and other conditions that plagued women was to experiment on slaves. The names that we know are Betsy and Lucy and Anarcha, but we know that there are many others that he experimented on without anesthesia, painful procedures that Lucy, we know herself, underwent 100 painful procedures to perfect this technique that we sort of use today. And yet I was on call just 2 nights ago, and I called for the Sims retractor for a delivery that we had done. So we still have the legacy of these sort of, barbarians, honestly, that still exist in our modern healthcare system today that we have not really expunged. If we think back to the US Public Health Service study, many of you are familiar with this Tuskegee syphilis study, in which, even after we knew that penicillin was curative for syphilis, we let African-American men who were enrolled in this study go untreated in the name of sort of following the natural history of this disease. And so that has left a legacy of mistrust in communities. And as we talk now about the COVID vaccine and vaccine hesitancy, it's no wonder that there's more hesitancy in many communities that are rightfully mistrustful of the medical system. And then Henrietta Lacks, if we think about this African-American woman whose cervical cancer cells were used to perpetuate this HeLa immortal cell line that is used in scientific research even today, but that was done without her consent and without any sort of remuneration of her family until recently. When I talk about these contributors to health and healthcare inequities in our space, I often talk about the fact that, if we use this rubric that comes from the American Journal of Public Health, we acknowledge that there are probably a few patient level factors that might contribute to health inequities, so things like beliefs and preferences. But certainly we own a lot of this on the side of the provider, so our own implicit and explicit biases show up at the level of the clinical encounter. And all of this happens in the greater healthcare system that is really structured and financed, and healthcare is delivered in ways that drive inequities. What I always feel is missing from this rubric is the structural factor. So this is where our patients live and they work, in terms of thinking about things like food insecurity, racism, poverty, and wealth that all really impact the health and healthcare of our patients. I think it's critical to sort of acknowledge the underlying underpinnings of racism. Congresswoman Clark talked about the social determinants of health, and I think that these are incredibly important in the work that we do to underscore why patients might have adverse outcomes. But we really need to understand the racist policies that came to imbue these social determinants of health, things like redlining. And so I'll just show you the redlining map. So the redlining policies in the 1930s were ways in which banks were, these metropolitan maps that were created disseminated across the country that sort of told banks how highly rated areas were in terms of risk of insuring home loans in those areas. And those areas that were in the red were areas that were deemed to be of high risk. And those were the populations that had lots of African Americans in them. And that's a legacy that we live with today that really has driven the social determinants of health as well. And so you can see Lexington up here in the upper left corner. There are no red areas in Lexington, which I think is an important sort of historical thing that we can sort of think about as a community. And so lastly, I'll just end with a few, in this segment, with a few things about how our biases and racism show up in the work that we do. We know that there's a great study that was done that looked at physicians who cared for patients with possible cardiovascular disease. And physicians that participated in this study were randomized to see a video vignette of patients with a particular cardiac concern. So the patient sort of read a standardized script. All of these 8 trained actors read this script, and a provider was randomized to see one of each of these patients read this script. So you can see that they vary by sex, they vary by race and by age. And what we know is that after viewing those scripts, physicians were much more likely to refer white patients on for additional cardiovascular evaluation than they were for Black patients. And we know that in other studies that that's been mediated by the strength of preference that people may have for white patients. So if you are more likely to favor white patients, you're more likely to send those patients on for additional work. And so this slide sort of shows the same thing. Those same implicit biases that people have been tested on have been shown to affect their likelihood of prescribing narcotics for African-American children, for example. And so what I would say here is that it's hard to say that our system is broken. It was never broken. It really truly was built in this way. And as my kids who are right now being babysat by their electronics might tell us, it is time really for a system reboot. So I am going to pause here and I will turn it over to Dr. Carter for her portion, and then we'll come back and talk a little bit about what we're doing in the healthcare system today to ameliorate some of these inequities. So thank you.
All of us are aware that the U.S. labor market really over the past 10 plus years has continued to have uninterrupted job growth. So this has certainly been something that we've been able to see for all individuals across the board, which is, you know, incredibly positive. And then U.S. employment rates certainly have been the lowest over the course of 50 years. If you look from the 60s through the beginning of 2020, and this is all coming from the US Bureau of Labor Statistics. And I wanted to demonstrate this trend, which of course is showing us the unemployment rates, which generally have fallen over this 50-year period through 2019. But take a look at what happens when we look at this and stratify by Black and white workers, clearly demonstrating that Black workers continue over time to have elevated rates, sometimes twice, if not 3 times that of white workers, particularly as we move through what we refer to as the Great Recession in 2008. And even if, and I'm someone who does research, even if as we moved through to the next data point, as we begin to see these two lines get a little bit more close together, even if those in the next data point, those two lines were to cross, it wouldn't make as much difference as many of us would like it to, because of a different concept that some of you may have heard about. And we refer to that as good jobs. So good jobs in this country are really jobs that pay at least a median of $56,000 per year for those workers who do not have a minimum of a bachelor's degree, and at least $65,000 a year for those workers who have a bachelor's degree or higher. And this is based on the US Census Bureau and Bureau of Labor Statistics. And this is something that has become increasingly important, also because a series of important social and field experiments that have been done demonstrating in some cases that white applicants are 1.5 or even twice as likely to receive a callback for a job as opposed to a white applicants who are equally qualified. So this is something that permeates in a way that really speaks to not only the year-to-year economic compensation, but also the overall wealth accumulation. So here you can see annual earnings in good jobs from 1992 through 2016. And this comes to us from the Georgetown University Center on Education and Workforce Analysis. We're able to see that those in blue representing white individuals, red representing Black workers, and light green really representing Hispanic or Latino workers. We're able to see that these are incredible disparities that last throughout all of the different academic levels. So whether we're talking about those that are getting a bachelor's degree, whether we're talking about those with quote unquote middle skills or those with high school diploma or less, there continues to be these disparities throughout. And this is probably one of the biggest issues that we face is that the wealth gap continues to widen, particularly after we move past 2008, and these lines have continued to widen as we move into 2020, of course, in the setting of so much of what Dr. Bryant has discussed with the COVID-19 pandemic. So the ability to accumulate wealth has really been stagnated in very critical ways for individuals that are Black and of color. In particular, we can certainly think about our local Boston disparities with respect to the 2015 report that was put out, The Color of Wealth in Boston, as a part of a joint publication through Duke University as well as the Federal Reserve Bank. And many of us saw this manifest in terms of the Boston Globe article, which was generated based on some of these data. So generally here in Boston, we're able to see that for home ownership, nearly 80% of Boston white residents do in fact own a home. And this is compared to 33% of those that identify as being African-American or Blacks from the United States. Similarly, when we talk about people that have retirement accounts, 56% of white residents here in Boston do have these retirement accounts as opposed to only 20% of those that are United States born African Americans or Caribbean Blacks. And then certainly for median wealth, which really was a staggering number that was shared in the Boston Globe article, $247,000 for on average for median wealth for white residents, as opposed to $8 for US born Blacks, or Dominicans. So really, essentially zero. That's a zero is what that is when you look at that statistically. So we can see that these disparities are certainly ones that locally continue to permeate and take effect. So overall, just thinking about these both US national and local prosperity, we can say that the data demonstrates that despite year-over-year expansion of labor, we have some stark disparities for Black Americans, and much of that is based on systemic racism. And as Dr. Bryant mentioned, everything from redlining to education to jobs. And we see these higher rates of unemployment, we see less access to good jobs, and we see a lack of ability to build wealth. And it's systemic and very much intentional. So the rising aggregate magnitude of the wealth gap is one of the reasons where it's essentially a call to action, both locally and nationally, for people to think more intentionally about how to improve these stark disparities. And certainly in US healthcare workforce, we can't say that we're not also in many ways a part of the problem. We have disproportionate representation of at different levels of healthcare. So for those that diagnose, and that certainly includes physicians and certainly nurse practitioners, we have a dearth of individuals that are identifying as Black being in those diagnosing professions. And the majority of those that are in these health-related professions are actually health aides or attendants. So that in and of itself is its own disparity. And when we talk about health, similarly, when we look at health service workers who are generally our health aides, they're more often Black or of color, and then they also have obesity rates that tend to be 3 times those of our health diagnosing professions, so physicians and nurse practitioners. So again, really relating to those COVID-19 disparities that we've all heard so much about in terms of those in Black and Brown communities being twice as likely to have a negative outcome related to COVID-19 from a mortality perspective. And certainly I just want to end on talking about what we're doing at Massachusetts General Hospital, certainly beginning with data and really using that data to generate policy and practice as well as programs is our #1 focus. So from everything from looking at surveys that we use and data that we accumulate within our annual report on equity and equality, and really pairing with a series of offices and divisional levels, so departmental and division equity champions, and they are critical to this work, as well as our MGH Center for Diversity and Inclusion, our MGH Office of Equity and Inclusion, our Center for Community Health, and our Disparity Solutions Center. And using that collateral in order to leverage recruitment and retention, as well as mentorship and professional development. So certainly we're doing our implicit bias training, which we're now just calling anti-racism training. We actually had a long internal tension around calling things racist or anti-racist. And so we're now finally able to move into that, doing microaggressions training, trying to make sure that individuals that are coming through residency or students do in fact have the right toolkit to talk to actually address folks that are talking to them in a way that is not reflective of dignity and respect, and also maybe based on racial bias. And then also doing upstander training for those individuals that are working with or adjacent to colleagues of color that will be able to be more likely to actually call out racism or any ism that's happening within the workday. So we also have a series of pipeline programs where we're trying to increase and improve The numbers of individuals of color who are coming through in terms of folks we're hiring, and that includes a visiting clerkship program that works throughout the United States to bring students of color to our brick and mortar, completely on a scholarship basis. Whether that's also the SRTP or Summer Research Training Program that we bring folks across the US for 3 months, both at the undergraduate level and at the medical school level, to let them have an opportunity to do research and also get an experience of what it's like to be at MGH and be a part of some of these policies and practices. And last but not least, we have identified a senior vice president of equity and community health, who's also helping to lead so much of this, Dr. Joseph Betancourt, and really trying to blend this world of clinical community and also equitable care on all these 3 levels at Mass General. So, and we'll hear more about this 10-point strategic plan that is happening at the level of the corporate folks or Mass General Brim on the part of Dr. Bryant. So I'll stop there.
So thanks so much, Dr. Carter. That was amazing and super helpful in terms of framing sort of why workforce diversity is so important and where we're going with those themes. My next task, I think, is just to jump a little bit into where do we go from here, to sort of piggyback on some of the things that Dr. Carter said. In addition to my being a proud Lexingtonian, I'm also a proud native New Yorker, and so I can talk very, very quickly. So I'm going to rely on the organizers to kind of keep me on time and just give me the hook when I need to wrap it up, so that we can get to the breakout groups, which I think is really going to be so important for our community. So I ended the first portion sort of talking about a system reboot being required, and Dr. Carter has talked a little bit about how we can think about that in terms of our healthcare workforce. I will just give you some examples about what we are doing within our own department at MGH. Many of the things are sort of in parallel to what's going on at the greater hospital level. So we have a department diversity and inclusion committee, and we do work on issues of hiring, but I won't touch on much of that because of what Dr. Carter has just gone through. But we also really work on sort of raising the awareness and the skills for our department around anti-racism training, around being aware of the equity issues that we have with our patients, and then also we move forward issues in terms of those health equity efforts. Dr. Carter mentioned the annual report at MGH on equity and healthcare quality. And so I think that this is really an important feature of what we do at MGH, is that we know that these inequities exist and we need to get them out there front and center, not just for our own population of our healthcare providers, but also across the nation. So this is publicly available. This is available on the MGH website. You can Google this report, and sort of every year, every 2 years, we go through those outcomes that are most critical to us at MGH and look at them by race, ethnicity, by language proficiency, by insurance, and understand where we have gaps. That work is done continuously. These reports are just generated on an annual basis. And what I'd like to do is sort of give a little bit of a shout out to Efren Flores. So if I go through this one, our last report was released in 2018 to 2019. And if you go through it, they did sort of a photo series of sort of highlighting sort of 4 physician leaders who are sort of front and center in some of this work at MGH. And I will just be proud to say that 2 of us are from Lexington. So Dr. Flores lives around the corner from me here in Lexington. He and I have never met in person, but this is our goal. But he also works on many of these equity issues. So anyway, go Lexington. Other work that we have done within our own department is really think about doing unconscious bias training that really, like, now we should be framing as anti-racism training for our entire department. And oftentimes we think about the providers, the physician providers and our midwife providers and our nurses, but it also encompasses people like our genetic counselors, our medical assistants, the people who work at the front desk, or even environmental services, understanding that all of those patients, all those people touch our patients in one way or the other, and we all need to be aware of the biases that we bring into our workplace. race. We asked all of our professional staff to complete an implicit association test. And for those of you who have not done this before, this is somewhat considered to be a gold standard in terms of assessing one's own biases. And I think that this exists in the resource page that you will have access to after these talks. We created a series of sort of race and equity town halls, as well as a race dialogues workshop to talk together as a community about how race shows up in our community and how we can move forward. One of the things that we heard most prominently from those conversations is that what people really wanted to have was a place where they could document the things that happen on a daily basis to them that were microaggressions or episodes of bias or racism or discrimination that either happened to them personally, that they witnessed happening to another provider or staff member, or that happened to a patient. And so what this is, I don't know if you can see my cursor, but in the middle on the right is our Inequity Inbox. And so that is an anonymous survey that people can fill out. They do not have to put anything about their name, their who they are, but they can just show us something that happened to them in their workday that wasn't quite right. And what we've been able to do with that is then to establish the landscape of the instances that happen in our department and bring them back to department members so that people can understand why it is so tough for people of color sometimes to show up. I will move on in the interest of time. Dr. Carter mentioned that the MGH has created this 10-point structural equity plan, which I think is really sort of masterful and really touches on so many elements that are quite important. So from things like documenting the inequities and moving forward to understand how structural racism shows up in the care that we provide to patients, but also thinking as academic leaders about eliminating racialized science in medicine. For many, many decades, there have been things that have treated race as a biological construct. So things like for our field, how likely is someone to be able to have a vaginal birth after cesarean delivery? There's a model that you build in race into that model, and that really should not be the case. And so acknowledging that using race is really a proxy for racism, and sort of pulling out now race from all of those models and constructs because it's inappropriate to use them to predict what's going to happen to a patient. Understanding the role of security. So as we talk about police brutality around the country, we really need to understand in the hospital environment, our police and security, how they are viewed and what their policies are around equity. And so I think that was a brilliant move to include that. And then really, I think echoing what Dr. Carter had said is sort of assuring a living wage, educational development, and access to care for our own employees. So we oftentimes focus a lot on the healthcare providers, but we have many, many people in our community that also need to be looked out for and making sure that they have a career ladder within our institution and our organization. And a lot of this work is sort of echoed and sort of rolled up to the corporate level to Mass General Brigham, which is formerly Partners Healthcare, in this program that's called United Against Racism, to really move forward anti-racist policies and agendas across the entire enterprise. And so very proud of those efforts. I just want to turn very quickly just to my work at the Massachusetts Maternal Mortality Review Committee. So this is from the New York Times that talks about why America's Black mothers and babies are in a life or death crisis. And the tagline is really true, which is the answer to this disparity in death rates has everything to do with the lived experience of being a Black woman in America. And so as we review cases of women who died in pregnancy or after pregnancy in Massachusetts, what we know is that our rates overall in Massachusetts are really quite good, but we do still very much have a persistent disparity between Black women and other women. And so at the national level, I was proud to work on a task force that really started to build in sort of specific ways that we could look at how discrimination, how interpersonal racism, how structural racism show up in the contributing factors to the death of a woman in the United States. And so this is now part of the form that we use nationally to review maternal deaths, to really recognize the fact that racism is very much a contributor to deaths amongst African-American women. We also think about legislative solutions, and this is part of, hopefully what we will all talk about in breakout groups. So just 3 days ago, the governor signed into law what we call the Disparities Act. So it is a special commission that's going to be elevated to examine and make recommendations to reduce racial inequities in maternal health in specific, but was advocated for by many constituents and many stakeholders. And so we're very excited about what that commission will bring. And then again, there's just the role for advocacy for all of us. So as we, in our professional organizations, go to Capitol Hill to argue for programs that may reduce inequities, every time we go, honestly, the Massachusetts delegation is like, yes, we've got this. Yes, we already support this. Like, what else do you have? So I really would applaud all of our lawmakers in our state, including Representative Clark, Congresswoman Clark, for their efforts to really help to reduce inequities in this space, but always are encouraging us to sort of think more broadly broadly and about what else we can sort of add to really bring this issue to the forefront. And so I think I will end here, just in terms of other things that have happened that really are, I think, emblematic of where we're going. So the statue of J. Marion Sims has been taken down in New York City. This is a picture of President Clinton issuing an official apology to one of the Tuskegee participants in the Tuskegee study. And that apology was penned by a woman named Thena Durham, who was a Black microbiologist at the CDC who I had the occasion to meet and who really sort of wrote that entire apology. This is a portrait of Henrietta Lacks that is now in the National Portrait Gallery, but more importantly, the NIH has come around to issuing an apology to her family and really including her family in sort of how those cells are being used in scientific research now. And our own professional society has sort of had this collective action on addressing racism in which they are acknowledging and officially designating the days of February 28th and March 1st as the days that bridge Black History and Women's Health Month as a formal acknowledgement of the slaves that were operated on by J. Marion Sims. So we are getting there, we are moving forward, but I'm hopeful that in our breakout groups, we can talk about more things that we can do within our own community to move this work ahead. Thanks so much.
Awesome. Thank you so much, Dr. Bryant and Dr. Carter. We really, really appreciate you giving us the time this morning. We are going to move to breakout rooms. So I just want to give everybody a quick heads up before we go that we are asking everyone to abide by our guide to civil discourse. And there's one question. I'm going to do the discourse, and then I'm going to have Christina go back to the slide on our question for the breakout rooms. And we are really lucky that Dr. Bryant is going to be able to stay for a little while, and she's going to pop into a few of the breakout rooms so she can hear kind of the conversation that's going on, as will a couple of us from the Human Rights Committee, which we typically do when we're in the big room. We walk around and check in on different tables. So a few of us will be popping in to the rooms to check on the conversation, see how it's going, and try to make sure everybody has an opportunity. But just really quickly, we just ask you to recognize a person's right to advocate for ideas that are different from your own, to please respect each other, speak as you would like to be spoken to, agree to listen and not just sort of hear, but to actually try to listen and understand what the people at the table or in your small group are also saying, and speak for yourself, not other stories or things that you've heard, but from your own personal view, preferably. Those I statements are strong. And I'm not sure what happened there, Christina. We just lost the slides. Oh, there we go. I just agreed to let everybody have a chance in your group to talk. Some of the tables might be, or some of the small groups might be a little big. With that, I am going to let everyone sort of move to breakout rooms. And again, I just want to say thank you. Our main question we're asking for you, and there's a few other in the breakout rooms that your facilitators have. Please note there's a few doctors that we have and nurses and some other healthcare practitioners that will be in different rooms that we've tried to sprinkle out so you can actually have some medical background in your groups. But here's our question. Given everything that you heard and talked about today, what action will you take or can you take, and how will you be accountable for following through to try to improve the situation that we have currently in existence in healthcare and healthcare outcomes? Without further ado, I think people are everyone, please, turn your video and you can put your mute button off, and then we're all going to come back at the end.
Thank you so much, Tanya, and thank you really to everyone. This really has been a fantastic morning. So I just wanted to help to kind of wrap up. It's not so appropriate for me to do the wrap up because you guys have really done an amazing job of work. I had a chance to pop into many of your breakout groups and heard some really great ideas. And so wanted to go over a few that I had heard. I think that the document that collates everyone's top 4 will be made available to all of you. And I would encourage you all to read through them because it's really an amazing document, an amazing place to start. So really, where can we go as a community? I just wanted to come back to reflect on the slide that I had presented, because what I heard from people was, you know, I'm not in healthcare, what can I do? The things that are on this rubric really are about healthcare, but what I said, and I think we all sort of echo, is that the structural factors, how people come to the healthcare system, are so much more important than many of the other things that we do within the course of the healthcare system. And so these are things that we certainly all can influence as a community. And so things that I heard from you all and also from sort of friends that I had polled, some ideas that are floating out there is just everyone should commit to understanding their own implicit biases, consider taking your own IAT if you haven't, and understanding then where biases show up in your own lives. Think about the privileged classes to which you might belong and think about intersectionality and all of this. So, how does your privilege show up? Really understanding the historic roots of racism to understand how we got to where we are is what I heard. Thinking about ways that you can move your own families and organizations towards anti-racism. So whatever it is that you do in your life, take inventory about how the data that exist in your space can be informed to inform policy. Think about forming a book club or other kind of learning forum for some of this work. I definitely heard and had heard before this about, committing to buying at minority-owned businesses to the extent that we can sort of improve the economic conditions of many of our populations. That will go a long way to improving health. So Dr. Carter's suggestion was considering buying 25% of your food, services, or gifts from minority-owned or minority-facing businesses. And I know that the Association of Black Citizens of Lexington is working to sort of curate a list of those businesses in the Lexington and sort of surrounding areas. Donate to health equity organizations, commit to educating your own children about racism and bias, thinking about how we can support social justice teaching in the early education level, because children will go on to become adults and sort of kind of to perpetuate this system if we don't fix it now. And then consider how you can improve the pipeline of children of color interested in science and the health professions. Advocate for legislation, so call your representatives. Like I said, our representatives are usually on board, but call them anyway. Make space for people of color to lead. And we just talked about some of the structural factors, food insecurity, housing. I did hear folks talk about literacy and how we can improve literacy, because as goes overall literacy, so goes health literacy. So when patients come to our offices, the best, if they are well educated, well empowered to advocate for their issues, they will do better in the healthcare system. And so those of you who work in library science or sort of work in any educational fields, that's a big help for all of us. One of the most important things I heard is the youth have powerful voices. So listen to them. They are helping us to lead this way. And if you are an employer, think about how you can get your employees to take sick days when they need them. We've learned a lot from this pandemic about how that's influential for health, how they can get to their healthcare visits. And, as we're thinking about COVID vaccination, if vaccine hours are like not conducive to work hours, that's not going to work out. So think about what you can do in flexibility. And this is just my last slide. Sharing data and statistics is a great way to start these conversations that I saw. Talking to your friends and family in healthcare elsewhere, right? So even if you're not in healthcare, if you know a nurse who is in Texas, ask her what she knows about these disparities and what she and her organization are working on to fix them. I heard create inequity inboxes in your own workplaces. So create a repository where people can anonymously report the things that are happening in their daily lives that may influence their experience. Those who have lived experience have to be at the table. So like I said, make space for minority folks to lead, not just to check a box, but as stakeholders and fellow leaders with a defined role, and intentionality is the right word. Creating a specific position in the Lexington governance with a focus on equity. And then a great idea was really that, there's lots of efforts that are going on, whether at faith-based organizations or educational spaces, but can the town of Lexington convene all of those organizations already working in these spaces and lift them up and make sure that things are not being duplicated or best practices are being spread around. And then really respecting and reflecting on the history of how we got here. So this system was designed to get the outcome that we have now, and let's not be destined to repeat this history. And last, we may have gotten, for many of us, the outcomes that we wanted out of the most recent election, but, not to be super political, but there's always power in voting. So let's remember that as we move forward. So those were the things that I collated. I really am deeply appreciative of the chance to talk about this morning, and look forward to continuing those communications with all of you in the weeks and days to come. Thank you. I'll turn it back over to Mona.
Thank you so much. I mean, if we had been all together like we usually are, stuffed with bagels and been through this would be 3 minutes of applause. So you can't really hear that on Zoom and across all the living rooms in Lexington that are watching you, but we're so fortunate to have had this program. This has truly been an incredible event, and there's so many people to thank, and I appreciate your patience in hearing those out. Firstly, our incredible speakers, Assistant Speaker Katherine Clark, who took time out of her schedule to elevate this topic in a more public way, our very important experts, Dr. Jocelyn Carter, and our main guidance speaker, Dr. Allison Bryant, who just her level of expertise is up here. And, but she really took the time and effort to really bring it down to a level that we can understand and where we can engage. I would like to thank the incredible organizing team who has been spending many months pulling together ideas, resources, publicity, and the epic task of managing the Zoom logistics. The co-chairs for this event were LHRC Vice Chair Tanya Gisolfi McCready. The community co-chair was Jody Finnegan. The other members of our very active organizing group, Deborah Armstrong, Nancy Brodsky, Sarah Cuthbertson, Carolyn Flace, Larry Freeman, Umber Iqbal, Christina Lynn, Catherine Riley, Melanie Thompson, and Gwen Wong. Every one of these people contributed in ways that really made the event what it is today, and without them, that there would be no event. I would also take an opportunity to thank the 40+ facilitators across multiple demographics who took the time for training, reading huge amounts of background information, getting multiple emails and texts, and then finally showing up this morning and facilitating a small group conversation with you, with sensitivity and grace and the restraint to hold back their own voices and let the community speak. These are people, for those of you who don't know, many of them come back year after year. They've gotten training, refresher training, and they're really, really invested in these work. And the Lexington Human Rights Committee and the community at large is lucky to have these people as true partners in the work. Speaking of partners, we want to thank the following houses of worship for their financial support and larger commitment to the work of dismantling racism. Fallen Church with Fallen Response to Racism, First Parish Church in Lexington, and Pilgrim Congregational Church. A few quick mentions. I believe that they're going, along with some other houses of worship, to present I'm a Good Person with Debbie Irving, which is on Sunday afternoon. Please sign up. Before that, our Human Services Department, as part of their Diversity, Equity, Inclusion series, will be hosting a virtual event on the psychological consequences of racism in the Black community. And speaking of the Black community, I know all of us are very excited about the wonderful new banners put up by ABCL, Association of Black Citizens of Lexington, which is really doing all of us, especially our kids, but all of us, a great service in teaching us about our own Black history in Lexington. So I hope that while we're walking, since we have so much time to do that now, that we will enjoy those banners. This program was live streamed and still is being live streamed by LexMedia, who recognized that this was a talk that could not wait and made the extra effort to stream this talk live. Thank you so much to LexMedia. They will also be streaming Lex Pride's afternoon program, Intersectional Approaches to Anti-Racism, at 3 p.m. And if you haven't signed up, I'm not sure if there's still space, but please do go to our LexingtonMLKday.org website to sign up. Grace Chapel will continue to be a collection point for donations. Details are also on the website. And we have a virtual parade where you can record yourself for, I think, 90 seconds or 45 seconds. I can't remember the details. Marching, as we could not be together this year due to social distancing rules. We so appreciate you contributing your videos as well, because we want this to be a lasting. This is a year like no other, but this is an important year for us to come together. Last but not least, we thank all the community members who chose to spend their morning with us, especially the high school students who likely are not even listening because they're filling out their community service forms, which are due within an hour of the end of this program, so they get credit. I know many of you came for the service hours, but I hope that at least some of you left with much more. Your generation will have to choose to make the changes desperately needed to dismantle racism and thus save lives. Thank you so much. Our full report will come out in the February meeting of the Lexington Human Rights Committee. Thank you so much, and I hope you have a wonderful MLK 2021, MLK Day 2021. Thank you so much, and God bless.